Hello.
रात को भी मेरा फ़ोन बिज़ी क्यों रहता है?
Hi, students. Welcome back. Sorry for the delay. It's been raining cats and dogs in this part of the country. I hope wherever you are, you're all fine. And we are having a good power backup, so we are online. And just that there were some initial niggles. So I hope you're all here. And we are going to talk about a very important topic in our preparation for our MBBS final exam. And Farre is definitely the topic of gynecology is CS cervix. There are two topics in gynae which you should never leave without reading. That is, never leave for the exam without reading. One is CS cervix, other one is PCOS. Like in obstetrics, I keep saying PPH and fetal surveillance. These four chapters you should know as students of obstetrics and gynecology. All right. So when we talk about CS cervix, it is that cancer of women which is the most common gynecological cancer of the women in our country. Yes, if you say overall the cancers in women in our country, we say CA breast is more common. Yes, many years back, something like 10 years back, CA cervix was the commonest cancer. And I'm a proud gynecologist that we have brought it down to the second most common cancer of women. So in women, the second most common cancer is CA cervix, but genital cancer most common is CA cervix. So when we talk about CA cervix, what is the picture in your mind you should have? A thin woman, a poor Indian woman who belongs to the low socioeconomic status and has got very less resources on herself, hygiene where there's a problem, and of course promiscuous lifestyle, especially of the male partners. I'm not saying that female partners are not promiscuous. I'm not trying to just put it on the men, but yes, it is also about the women. So multiple partners and partners with sexually transmitted diseases and early intercourse and people having low socioeconomic status where hygiene is a major problem. So keep this in mind when you talk about CA cervix. Look, you'll also get questions on CA endometrium. The CA endometrium is the cancer of the affluent women, the well-to-do healthy women, those who have diabetes mellitus, hypertension, obesity. Healthy women get CA endometrium, poor Indian women get CA cervix. Keep that distinction in mind. You will get cancer on questions on both the cancers, but you must remember of CA cervix as the most common genital cancer of women in our country. So cervical cancer, most common genital cancer of women, and it is associated with HPV in 99% of the cancers of the cervix. It is the HPV. Okay. Then most common cancer of women overall is CA breast. Now, when we talk about CA cervix, the HPV infection is the etiological factor, and 16 HPV 16 is the most common, and HPV 18 is the most malignant. I'll try to stick to the core basics which you should know when you're writing a theory paper and also when you're recalling in your viva. So yes, most common is 16 and most malignant is 18, but there are 50 other total serotypes. There are 50 serotypes which cause CA cervix. So don't think that only 16 and 18 you have to know. So yes, how do they bring about the cause? I mean, how do these viruses bring about the problem of CA cervix? These viruses elaborate the E6 and E7 oncoproteins on the transmission zone of the cervix. We'll be discussing about the transmission zone of the cervix, a little bit about the anatomy. We'll talk sometimes later when we're talking about the Pap smear. But remember, this elaboration of the E6 and E7 oncoproteins, it is, they inhibit the tumor suppressor genes. These E6 and E7, they inhibit the tumor suppression, so they in fact cause tumor proliferation. That's the meaning of E6 and E7 oncoproteins. Then what are the etiologies which we have to talk? Women with many partners, commercial sexual workers, partners with sexually transmitted diseases, then association with HIV 1 and 2, and association with herpes simplex virus 1 and 2. These are all the predispositions when we see patients with CA cervix. But remember, in addition to all those factors, must remember multiparous women, immunocompromised women, and low socioeconomic status. I've been repeatedly saying that because see, HPV. How does HPV get into the body of a woman? Practical. It gets into the body of the woman only with sex. Okay, very rarely the the HPV from the body on the surface of a body can find its way into the vagina. That's extremely rare. But most common way the HPV finds its way into the cervix is after sexual intercourse, when the man is loaded with the HPV. So yes, low socioeconomic status is the problem, where people may have many partners, and for them to have a clean sex life is a big problem. To have hygiene also during sexual intercourse, and access to a clean place to wash themselves off, that is also one very major problem in the low socioeconomic status. So yes, if you think of a hutment, a large area, a hutment where there are hundreds and hundreds of people staying in small huts, and those places where they have hardly any privacy, and when they get to have a physical relation, then to have an access to a bathroom, when most of the times they are going to the open fields to relieve themselves. So that kind of life when they're having, and when these men may be having many partners and bringing the viruses home, so this kind of lifestyle will allow the HPV to proliferate. So I've given you the reason why this low socioeconomic status could be the problem. In addition to the exposure, this low socioeconomic status plays a major role. Of course, smokers, I mean, smoking is there in all the cancers, head to toe, any cancer you discuss. I mean, I'm generalizing, but yes, most of the cancers, somewhere in the top or in the bottom of the list, smoking is there. And CA cervix is, smoking women is more likely to have CA cervix. So yes, what else is predisposing? The early intercourse, that is less than 16 years of life, if a woman has intercourse. And that, what is the problem with this early sex? That the transmission zone is just forming. So if you see, the transmission zone is somewhere here. It's around 1.7 to 2.3 centimeters from the external os. So somewhere you'll see the transmission zone. Now this transmission zone cells are just forming when the girl is a very young girl, let's say of 15-16 years. So that time when the cervix is having, see, the transmission zone is forming. This transmission zone is forming, and the fresh new transmission zone cells, the transmission zone gets a little exposed in a pubertal girl. It is a little internalized in a small girl like 5-6 years old, and when she gets pubertal, the transmission zone gets opened up, and then in a post-menopausal woman, the transmission goes a little bit back inside. So in a young pubertal girl, it is just opened up a little, and fresh transmission zone cells are being formed, and that time with the HPV goes inside. So early intercourse, early effect on the transmission zone, early CA cervix. Look guys, there are a lot of fundas in the chapter of CA cervix, and I would advise that all of you please concentrate on the topic at hand. It's going to get a little bit more intricate, so please do not get distracted. CA cervix has a lot of intricacies, especially when I'm talking about the Pap smear, the results, and the management. So please leave whatever else you're doing, and I'll look at your questions. I'm not trying to distract myself also when I'm teaching you, so you don't get distracted, right? So we're talking about the transmission zone, and early intercourse is predisposing, and then postpartum resumption of sexual life. What happens that when a woman delivers, all these transmission zone cells, this area gets shed off. Now what happens? This transmission zone cells start to grow again and make a new transmission zone. So when that new transmission zone is formed, and that time the man with HPV has intercourse with his partner, then also there is more predisposition to get the transmission zone affected by this HPV. So this transmission zone is the place where CA cervix starts. Transmission zone is the place where CA cervix starts, and the cells here in the transmission zone are dividing cells, and they can be affected by the human papilloma virus. We are going to discuss a little bit more about this just a little while later, right? So, HPV vaccine. This I'm telling you before itself, because there's a lot of talk about HPV vaccine, and a lot of MCQs keep coming. So I thought I'll just finish off here now. We are telling you the etiology is human papilloma virus, and human papilloma virus, how can we contain it and how can we prevent cancer of cervix? So there is some role about the vaccine. I'm not saying it's got a foolproof vaccine. There is some role of the vaccine definitely. So it is made against the L1 major capsid protein of HPV. So what is the meaning of a capsid? Capsid means roughly the capsule of the human papilloma virus. So the capsule of the human papilloma virus, against that the L1 capsid, the first level capsule of the human papilloma virus, against those proteins, this this vaccine is made against the L1 capsid. So this also was an MCQ. What is the principle of the HPV vaccine? Then this L1 proteins, they are assembled in labs to become non-infectious virus-like proteins, VLPs, virus-like proteins. So they are non-infectious, and when they are introduced into the body of the lady, she makes immunity against this virus. So not the active virus, the inundated virus like proteins are put into the body of the lady, and she makes resistance against that, and that's why this HPV vaccine works. So you must remember it is against the L1 capsid, L1 major capsid of the HPV virus. So I told you two new things. E6 and E7 oncoproteins cause the damage, the HPV causes the damage on the cervix by the E6 and E7 oncoproteins, and the L1 capsid is the protein against which the vaccine is made. These are the things which keep coming in your exams. Right, let's go and see the HPV vaccines which are there right through the ages. So the first vaccine was the Cervarix. It was bivalent. It was against the two viruses which I told you. The most common is 16 and most malignant is 18. So this was only against two. Then the Gardasil 4 came. Gardasil 4 also included the 6 and 11. So those 6 and 11 are the ones which cause the vaginal vulval warts. So this condyloma, those vulval warts, for that 6 and 11 was included. Now the latest vaccine which is being discussed and which is coming in your exams regularly is the Gardasil 9. It's a nonavalent vaccine, and this nonavalent vaccine, nanovalent is not the right, it's a nonavalent vaccine 9, and this nonavalent vaccine is against 9 serotypes. So these serotypes came in one exam. I was really surprised that you have to mug up the serotypes. It actually came in one exam. So 6, 11 and 16, 18 you remember. Then 5 more have been added, 31, 33, 45, 52 and 58. And if you can mug it up, great for you. So this did come in exam. They gave you 4 examples of these 9 viruses jumbled up, and you had to tell the correct 9 viruses against which the vaccine is made. So Gardasil 9 or Gardasil 4 or Cervarix, what is the schedule? So we are now giving only Gardasil 9. So iska schedule kya hai? You should know that. Schedule is, if you give it today, then you repeat it after 2 months, and then you repeat it after 6 months. So that is the schedule of this. Now let us stop and try and understand HPV once again. Now this is where I want you to have core understanding. HPV causes CA cervix. You give a vaccine to prevent the HPV from acting. The vaccine is Gardasil 9. It is against 9 serotypes. And what did I tell you is the cause of CA cervix? There are 50 serotypes. Concentrate. There are 50 serotypes which can cause CA cervix, and our vaccine is only against 9. In fact, these two are only for the warts. So only 7 serotypes, the high risk types which we are using, we are making the vaccine. So only these 7, against these 7 we have a vaccine. There are something like 45 plus more viruses which could be causing CA cervix. So this is not a foolproof. It is not a foolproof vaccine. It is based on the principle of something is better than nothing. We are giving the vaccine against the major virus serotypes. Yes, so it is something better than nothing. So what am I trying to tell you here repeatedly? That give the vaccine to all the women. Yes, prevent all women from CA cervix, correct. But you're not giving them a surety that you're definitely not going to have CA cervix. So give the vaccine, but continue the screening. Yes, this is what comes in your exams. Give the vaccine, but the screening doesn't stop. She has to go on coming for the Pap smear, which is the best method of screening for CA cervix. So do not get confused there. Give the vaccine, but always have the screening continuing. Right. So yes, so if you give this vaccine, you may think that it is a very good vaccine. Now let me tell you a little bit more detail, that when you give this vaccine, it prevents CA cervix up to 90% if it is given before exposure. And then suppose if it is given after the exposure, that means the woman already had sex with the person who had HPV, then the effectiveness is only 40%. So it prevents CA cervix 90% if given before exposure. Given after exposure, it is only 40%. And this 90% and 40% prevention. You may think that 90% is a good value. Sir, is why sir saying that it is not very good? 90% prevention to hai. Arey, this 90% prevention is only against these 9. Only against these 9 serotypes. 9 serotypes. That's why you continue giving the Pap smear screening protocols to this woman in spite of the vaccination. So yes, given after 9 years to all the girls and up to 45 years. Yes, 6 to 25 is what they say, but 9 to 45 they want to give it to all the women. But yes, have you forgotten that the virus goes to the woman because of the man having intercourse with her? Don't forget that part. Yes, now this is where we are missing out on a very important part, that you're talking about CS cervix in women and it is because of HPV and you're giving a vaccine which is against these 9 serotypes. ठीक है भाई, you know the serotypes, okay, very good. You also know that this is not foolproof, so you must continue the screening. Great. You understood all that. But who is giving the virus to the woman? The man. So you will not treat the man? Will you not give the vaccine to the man? Yes, men should also have the vaccine. Plus, all men should have. So look at the plan. Look at the plan of all the companies which are making the vaccine. The plan is that all women and all men should be having the vaccine so that CS cervix doesn't happen. That is what is going to actually reduce it even more. And that kind of vaccination is going to take a lot of effort from all the governments in the world, not just Indian government. So yes, you have to think of the man who is giving the virus to the woman. So the men also should be prevented from harboring the HPV and its side effects. Okay, so men also should be taking. So women, you know, but also the men have to be given this vaccine. Right. Chalo, let's move on and see. How do you screen for CS cervix? So we told you the etiology, it is HPV, and I told you that something about the vaccination, which is important. There are more details, but we'll hold it for now. We are going with the core basics today. So when you're talking about the screening of CS cervix, so there are things which have come up recently that never forget the importance of a Pap smear. Pap smear is the best method of screening CS cervix. Goes without saying. But what is cost effective? What is cheap and reliable? That is what is known as visual inspection under acetic acid. Now, this I will teach you a little while later when we're talking about the result of a Pap smear. I'll come to VIA. Now, this is the time when I requested you that please stop getting distracted. Now we're getting into the deep end of the pool. We have to now understand this topic properly. Okay, so concentrate. So cost-effective method is visual inspection under the acetic acid, and best screening method is done by the Pap smear, because Pap smear has a sensitivity only of 47 to 62. So cannot be very, very effective. So that's why we say continuously do the Pap smear, regularly do the Pap smear by the protocols. So then there's a chance of picking it up, because the sensitivity is 47 to 62%. So if you do it regularly, there's a chance that there is something wrong on the cervix, you'll pick it up. So you will do this Pap smear, and that will reduce the incidence of CS cervix by 75 to 80% and reduces death by CS cervix by 70%. This was an MCQ which came in the NEET exam. What is the reduction of deaths by CS cervix if regular Pap smear is done? 70% reduction of death of CS cervix if you do Pap smear. That's why it's a very good test. And Pap smear is actually called the ideal screening test. It is cheap to do. It can be reproduced with reliable results on a large population, and it is easily reproducible. You know, you can do this and with good results in a large population. So that's why it is the ideal screening test, this Pap smear. Now, what is the site of taking the Pap smear? Pap smear is taken from the transmission zone, and this transmission zone, look, I'll try to tell you here. Quickly, we'll understand this transmission zone. So the epithelium in the uterus here, in the beginning, here, it is ciliated columnar. And then at the level of the internal os, the anatomy changes. This is the internal os, anatomy changes, but the epithelium continues to be the same. After some distance, this epithelium becomes plain columnar. It becomes plain columnar here. So that is the internal os again. So this is the histological internal os, and above that is the anatomical internal os. So this area is known as the isthmus. So this area between the anatomical interloss and the histological interloss is known as the isthmus. We'll discuss that in obstetrics later. Now what happens? This is the columnar epithelium here. This is the columnar epithelium, not ciliated anymore. Columnar epithelium. Now, the epithelium on the surface of the cervix. The epithelium on the surface of the cervix here. This epithelium is squamous cell. So this is squamous cell and inside is columnar cell. Now between these two, the columnar cells in the cervical canal and the squamous cells on the surface, in between these two, there are cells which are in the process of becoming squamous cells. They are cells in the process of becoming squamous. So columnar, when it is getting exposed, when the columnar, look at my hand, I'm trying to show you, the columnar cells are getting exposed in the external os. So when the columnar cells are getting exposed, they have to become tougher epithelium of the exterior part of the body. Like all the exposed parts of our bodies are squamous. So when you see the cervical epithelium inside, it is columnar. Cervical epithelium outside is squamous. And between that yellow area, that is what is known as the transformation zone. So this is that transformation zone here, the transformation zone, and this has got rapidly dividing cells. That's why this is the place. These cells are in the process of dividing. Columnar becoming squamous, columnar becoming squamous. Please see the chapter of CA Cervix in the app. It's a very important chapter, much more detailed, but we are doing the core basics here. All right. So understand, columnar becoming squamous and columnar becoming squamous. It is a normal thing in all the women with a cervix which is healthy. Columnar becoming squamous. That is the transmission zone. Now these cells are in the process of dividing. Columnar becoming squamous, columnar becoming squamous. So the HPV comes and acts on this area and the HPV corrupts the code here. What is the code here? Columnar, you getting exposed, becomes squamous. HPV comes here and corrupts the code. Columnar, you become abnormal squamous. Columnar was supposed to become squamous. Because of HPV, it becomes abnormal squamous. So where did the abnormal squamous cell start first? In the transmission zone. That's why a Pap smear is always done from the cervix, but we should have transformation zone cells. Remember this. They will ask you these questions that if you do a Pap smear for screening of CA cervix, you know it can start in the transformation zone. So if your Pap smear does not have the transformation zone cells on the slide, then you're supposed to repeat the Pap smear. That is what is the importance of the transmission zone. So transmission zone is more prone to infection by HPV and thus cancer cells are continuously dividing here because this cells are continuously dividing. HPV will act on this dividing cells. The resting cells above and the resting cells below do not get affected by the HPV. This rapidly dividing. So that's why it is taken from the transmission zone. Now, when you're taking the Pap smear, before taking the Pap smear, consider it, guys, very important part of the class. Okay, when you're taking the Pap smear, 2 days prior to the Pap smear, there should not be any sexual activity, no spermicidal jelly, no douching. She should not be in periods, and there should not be any infections, no vaginitis, no discharge should be there. So method of taking a Pap smear, it is a routine Pap smear is taken by air spatula. You can also take it by a cyto brush. You can take it by a cyto brush or a cyto broom. These are the methods of taking the smear. So you take the air spatula, suppose this is the cervix and this is the air spatula. You rotate the air spatula 360 degree once. Just rotate it 360 degree once. You don't go on doing this, okay? A lot of interns and some of my first day, second day PGs keep rotating it like this on the cervix. If you keep rotating it like this, you are scraping the cervix and it is going to bleed. And when the cervix bleeds, your cells with the blood, if you plate, already the architecture of the cells will be compromised by the RBCs. So that's why you rotate it just politely once on the cervix, you'll get the cells. You're not taking a biopsy, you're just taking a smear of the cells. So that's why you rotate it 360 degrees once, 360 degree once, and then plate them on the slide. Now when you plate them on the slide, do you allow them to dry? No drying, please. No drying of the smear. Yes, you should not be drying it up at all. Look, suppose this is the slide. I have picked up the remote here. Now see here. I have plated the cells. I've taken a smear from the cervix. I've plated it on the slide. Now this slide goes into the Coplin's jar, which has the fixative. We fix it up immediately. We don't let it dry. We don't keep it under the fan to dry. You don't blow on it, okay? Don't let the cells dry. Drying artifacts will spoil the architecture of the cervical cells. So I don't want it to dry. In fact, moment the smear is taken, it is fixed. So how do you fix? 95% ethanol and placed in the Coplin's jar and then sent for staining. You send it to the cytology lab. Cytology, you're taking cells. That's why it is called a cytology. Sent to the cytology lab for staining by the Papinculo stain. Pap stain, Papinculo. Greek gentleman on whose name this is made, the Pap stain. So you plate the cells on the slide and then fix it immediately. Do not let it dry. And what is the fixative? 95% alcohol, right? So this is the Coplin's jar. You see this Coplin's jar has this vertical serrations, so you can hold 4 slides and these 4 slides can be sent. You have the 95% ethanol in this. So this is the iron spatula. You see it has got a long end and a short end. So the long end goes inside, short end stays outside, and you rotate it 360 degrees. You can also have a cyto brush or a cyto broom to take the smear. Now, how do you take the smear? I've told you. Then you fix it and then you send it to the cytology lab to stain it. So fixing of the smear and then staining of the smear. Staining happens in the cytology lab. You will just smear it. All right. Now this goes to the I can just tell you the stain contains what all. It has the hematoxylin, and it has the eosin, and it has the Bismarck brown, it has the light green, and it has the orange green. Now, why am I telling you the constituents of the Pap stain? Because this came again as a NEET exam question. What are the constituents of the Pap stain? So all of the following constants except, so maybe I'm a little rough. I'm sure the pathologist friends will teach you much better, but there are eosin, hematoxylin is there in all the smears which you know ever since your histology days. Then there are 2 greens and 1 brown. If you remember that much, I think that should be enough. We're not going to great details of the the method of doing the staining. That's a little bit out of purview right now. Let's get into the time and frequency of doing the Pap smear. So you should do a Pap smear for any woman after 21 years of age. Stop. Let's just listen to this and stop looking at the screen anymore. I'll stand here. Yes, you're not looking at the screen anymore. Yeah. So what did I just say? Do Pap smear for any woman who is after 21 years. Can you do that in my country? Yes. Can you go out of your house in your society, pick up all women who are 21 years and older, tell them to come for a Pap smear? You know how is a Pap smear done? Just now I told you that you open the vagina with a speculum and then you have to make a smear from the cervix. Can you do that after 21 to all the women in a country? This blanket statement is never asked of my students because this is a Western figure. Yes, women in Western countries, European countries, they are sexually active in a much earlier age compared to our country. All right. So yes, we don't say after 21 all women. Majority of the women in our country, I'm very sure more than 90% of women in our country are sexually active only after getting married. So when we're having the sexual activities starting later in life, we don't say 21. You don't write that in your books. These are, look, American recommendations hai, WHO recommendations hai. It doesn't become practice in our country immediately. How many 21 years that 21-year-olds who had a Pap smear? So we always say any woman 3 years after the first sexual exposure. That's what makes sense. Yes, there are women who get married at 2018 in a country. If they're sexually active and they're married, go ahead and do a Pap smear. I'm not saying no. But the blanket statement of 21, marriage mostly happens around 24, 25. Yes, our women are nowadays reading. They are worried about their education and their careers also. And then they want to get married. So 24, 25, 26, they get married. So when they're sexually active, then 3 years after that. That is what is a better statement than saying blanket statement 21 years ke baad sabka Pap smear kar do. Women are not sexually active in our country at that age. Okay, they are if at all they're married and you know that they are sexually active, that's a different thing. So any woman 3 years after the first sexual exposure, she should have the Pap smear. And then what is the frequency? From 21 to 29 years, you must do the Pap smear once in 3 years. So once every 3 years, you must do the Pap smear, and then after 30 years to 65 years, you can do the core test. Now, this core test is your hot shot question. It has come so many times that I must highlight it here. Yes, this came even in the exams in last year, 2 exams out of the 5 exams in a year, it comes. So, core test is basically in addition to doing the Pap smear, you also do the assessment of the HPV DNA in the cervix. Wait, who is having a Pap smear? देखो, topic खत्म हो जाएगा, फंडा नहीं बनेगा हमारा. We have to make a funda here. I go to the society with my intern friend. A lady obviously has to be with me. I go to the society. Look, I live in Noida here, and in Noida, I go to a society where there are something like 300 couples. So I take pamphlets and put pamphlets into every house. Please come to this clinic. We are doing a Pap smear for all of you free of charge because it is for screening of CS cervix. So all those who are married, please come to the clinic. So 300 couples were there. Out of 300, some 30 will come. All right. So those women who have come to me, they're all sexually active and they are worried about CS cervix. So I'm doing a screening test. They don't have any symptoms. So whom are we doing the Pap smear? We're doing the Pap smear to women who are at risk of CS cervix. Screening is done to people who are at risk for something, isn't it? If I'm living in Delhi and there is so much of pollution, I may be at the risk of getting COPD later in my life. So I should be screened for COPD. So they'll do a screening test on me. They'll not do a diagnostic test. So far I'm not coughing so much, isn't it? So we are at risk, so screening test should be done. So women who are sexually active are at risk. Now, what is the risk? Who knows? The husbands could be active in many other places. Who knows? She could be active in so many other places. Maybe having more partners. We don't know. So when we don't know, we just simply say that please come for the screening of CS cervix. What is happening in your sex life? We are not worried about that. We just want to make sure you're not getting CS cervix. So these women come to the clinic. And when I examine them, I open the vagina with the speculum and look at the cervix. Cervix looks healthy to me. There's no growth on the cervix. There's nothing hanging out of the cervix. There is no proliferative or ulcerative growth. It's a perfectly normal looking cervix. So that's a cervix. If it is having some, transmission zone abnormalities happening because of the HPV, that's what we have to catch. So if she's sexually active, then she could be active with the man who's got the HPV, or she could be active with maybe some other people and she's getting the HPV. How she's getting the HPV, we are not judging a patient. We are just finding out whether you're having CS cervix or not, whether you're having early change of CS cervix or not. So all sexually active women, we do the Pap smear who are at risk. So population at risk is done a screening test. So I do the screen test once in 3 years for women who are between 21 to 29 years, and after 30 years we do the core test. Now what is a core test? In addition to doing the Pap smear, look, I do the Pap smear, rotate it 360 degrees, and I plate the cells on the slide. Now plate the cells on the slide, that is done. After plating the cells on the slide, I will go and wash. I will take the same IR spatula and wash it in a media given to me by the immunologist. He will give me a solution in which I'll wash this IR spatula because the secretions may have the HPV DNA. So in addition to doing the Pap smear, I assess the HPV DNA, PAPs plus HPV DNA assessment. What is the benefit of this? Suppose the Pap smear is fine. I'm very happy. Come after 3 years. No, wait. I have looked for the HPV DNA also, and the HPV DNA is negative. This woman is not even exposed. Suppose she is 30 years of age. I do the Pap smear, it is fine. And I also do the HPV DNA. HPV DNA is है ही नहीं भाई. इसकी body में HPV घुसा ही नहीं अभी तक. Clean life है भाई. The wife is clean, the husband is clean. Obviously, that's why there is no HPV. So fine. If there is no HPV, then you don't have to come back to me in 3 years. Come back to me after 5 years. Because even if tonight she goes and have a coitus with a person who's got HPV, even if she has it tonight, it will take at least 3 to 4 years for the first change to start showing. So come to me after 5 years. So if it is only the Pap smear and it is negative, come to me after 3 years. But if I do the HPV DNA, she can come to me after 5 years. So that is what is done after 30 years of age. So if a Pap smear and HPV DNA is done and if it is negative, then you have to come to me after 5 years for a repeat co-test. But if only a cytology is done, that means if only PAPS is done, then once in 3 years, okay, if the HPV is negative, right? And then after 65 years, WHO says after 60 years. So they are not going to ask you WHO and all. What are the standard recommendations? This is the International Society of Pathologists, all right? So we are referring to Novice Gynaecology and giving you the guidelines, printed books. Like that, WHO will have a different guideline, Center for Disease Control will have a different guideline, and Americans and British College will have a different guideline. So we follow what is done in the hospitals. So yes, after 65 years, no more PAPs because the cervical epithelium gets so atrophic that the chances of C. cervix is negligible. So after 65 years, we don't do any more Pap smear. In fact, if 3 cytological smears are negative or 2 co-tests are negative after menopause, then also we don't do. So if 3 cytologies and 2 co-tests after menopause are negative, then also we say no more Pap smear. So by age, the criteria is 65 and beyond, no more Pap smear. And by menopause state, that after 50 years, if 3 Pap smears are fine or 2 co-tests are fine, then also we don't have to do any more Pap smear, right? So before I get into the interpretation, I want to see your questions. Let's say, HPV can be airborne transmission. Yes, HPV goes by the air from my body to your body to everybody's. Yes, it can move with the air, correct. But it cannot go with the air into the body of the lady. That's what I'm trying to tell you here. It does not get into the body of the lady. All right. So that's where you have to understand the body of the lady. To have it going to the cervix and harboring sexual intercourse is the most common reason. 99% of times. Yes, very rarely, very rarely monogamous relations, husband and wife not having any other relation, they can also have, this woman can have CS cervix. That's a very rare occurrence. Clean relation, but still they can have this thing happening. All right. So yes, more than 200 types. Yeah, the ones causing CS cervix are more than 50 types. That's what I want to tell you. Not all of them cause CS cervix. So you're not asking me. So in the more preferred liquid versatile manner, what is the difference between plasma and liquid cytology? All right, Ramzan, you're very correct in your questioning that liquid-based cytology is the modification of all the cytologies these days. And I always teach it. I was trying to restrict my class to the IELTS spatula. If you brought it up, let me just tell you nowadays what we do, that when we take the smear, liquid-based cytology, Ramzan has asked me, so just for helping everybody, those who are looking at the question, what we do when we take a sample, when we take cells from the cervix, we plate them on the slide here. So what happens? Some cells are on the back of my IELTS spatula. I do this, but still some cells are on the spatula and I'll miss it. So rather than smearing them on a slide, what do I do these days? I take a smear and I'll show you what I do. See here. I take a smear and then I wash the smear in a media. Suppose a test tube which has the media, and then I centrifuge the media at a high speed. When I centrifuge, all the cells will settle down. So I'll discard the supernatant and I'll take the sediment. All the cells will come in the sediment, and that sediment I will plate on the slide. So by this method, there'll be no sample loss or very less sample loss. So when I'm doing a IELTS spatula or a cytobrush and plating on a slide, I may miss the sampled cells. But if I do a liquid-based cytology, then the chances of missing the sampled cells is less. That's a method of doing the cytology. That's why I thought I'll leave it for my path friends to teach you. They will anyway teach you better than me. So, but never mind. If you ask me a question, I should be able to help. All right. So, chalte aage. Let's move on and see. Right. So, there are no more questions. So, consider it, guys. Moment to consider it very strongly now. Now, this is the time. So, normal Pap smear, you see you know, the cells which are superficial cells of the cervix and the deeper cells of the cervix, they stain differently with the Pap smear. So the superficial cells are acidophilic. So acid will be red, acid red, basic will be blue. So acidophilic cells are red, basophilic cells are blue, but these are all normal cells. Do not get confused. If you see red cells and blue cells, don't say red is unhealthy and blue is healthy. ऐसा नहीं है. These are superficial cells and deeper cells of the cervix. So yes, the acidophilic cells, and then these are the basophilic cells, like that. But can you see, these are not squares, these are polygonal cells. So clear cells, polygonal cells, clear cytoplasm, and darkly staining nucleus. So this is a normal Pap smear. Nothing is wrong with this Pap smear. This is a perfectly normal Pap smear. Now see this abnormal Pap smear. See the cell, the polygonal shape has been lost, the architecture of the cell is lost, and look at the size of the nucleus. There's hardly any cytoplasm which you're seeing in this cell. Can you see this particular cell? This nucleus is so big. So that's why we say atypical mitotic figures. We say the cell nucleus is so big. You know, nucleus is the place where cell division is taking place, isn't it? So such big nucleus, that means it is abnormal nucleus. So these are all cells. Can you see? These are all cells which are looking abnormal to me. So this Pap smear is an abnormal Pap smear. Yes, because the nucleus is big, the cytoplasm is very less. We say, no, nuclear cytoplasmic ratio reversal. We keep saying that. So these cells on the Pap smear are not normal. Normal cells in the Pap smear are like this. Now these are the Pap smear cells. These cells are having big nucleus. These are atypical cells. These are new cells on the cervix. What did I say last line? New cell on the cervix. Concentrate, guys. New cells on the cervix, neoplasia on the cervix, new cells. In the epithelium, where I have done this smear, I have done it from the epithelium of the cervix. I'm not taking any biopsy, please, guys. I've done it from the epithelium of the cervix. So from the epithelium of the cervix, I've taken cells, I've played them on the slide, and these cells of the epithelium are having atypical cells. So these are new cells on the cervix, neoplasia in the cervix. Which part of the cervix? Epithelium of the cervix. So that's why we call it intraepithelial neoplasia. Intraepithelial new cells. All right. Cervical intraepithelial neoplasia. New cells in the epithelium of the cervix. Once again, revise. What is this woman coming to me with? She has not come to me. मेरे पास तो आई नहीं थी पेशेंट. मैं उसके घर गया था, भाई पैप स्मीयर के लिए आ जाओ, आपकी शादी को 5 साल हो गए हैं. आई एम गोइंग टू स्क्रीन यू फॉर सीए सर्विक्स. Cervix देखने में एकदम normal था. Cervix was totally normal looking to me, and a normal looking cervix, I did a Pap smear. In the Pap smear, when I made a slide, in the epithelium of the cervix, I'm seeing, अरे बाप रे, so many abnormal cells are there. I look at the cervix again. Cervix तो normal है, but in the smear, so many abnormal cells. This is the fun of doing a screening. I know that there are abnormal cells before she becomes symptomatic. अभी उसको कोई प्रॉब्लम नहीं है, घर पे बैठे आराम से मेरे पैम्फलेट को पढ़ के ओपीडी आई है पैप स्मेयर कराने के लिए. I'm doing a screening test. She's at risk because she's sexually active. That's all. That's the risk. So I'm doing a Pap smear. Cervix is normal. The epithelium of the cervix showing me abnormal cells. So this is what is cervical intraepithelial neoplasia. So the number of cells which I see, how many are abnormal? Less than 1/3, 1/3 to 2/3, more than 2/3. That is what is giving me the grading of the neoplasia, grading of the new type of cells. So that is what is the dysplasia classification, that if the slide is having less than 1/3 abnormal cells, that is cervical intraepithelial neoplasia type 1, and if it is more than 1/3 to less than 2/3, CIN3, and CIN3 is, I'm sorry, CIN2, and if it is more than 2/3 cells are abnormal, then that is CIN3. If all the cells are abnormal, that means it is carcinoma in situ. So this is the dysplasia classification. CIN1 is less than 1/3, CIN2 is 1/3 to 2/3, CIN3 is more than 2/3, and carcinoma in situ means all the cells are abnormal. Now this dysplasia classification, if you superimpose on the Bethesda classification, not to get too worried about two different classifications, Bethesda means the same classification, slightly more easier to understand. CN1 is a low grade lesion, a low grade neoplastic lesion, low grade intraepithelial lesion, and CIN3 is a high grade, and CN2 is also high grade. So CN2 is a high grade and a CN3 is also a high grade squamous intraepithelial lesion. So yes, we call it the LGSIL, and this is called the HGSIL, low grade squamous intraepithelial lesion or high grade squamous intraepithelial lesion. So in the exams, they'll either ask you CN1 treatment or CN3 treatment. Why? Because CN1 is low grade, CN3 is high grade. So what about CN2? CN2 and CN3 both are high grade. So treatment of CN2 and CN3 is the same. That's why this easier classification is now asked. What is the treatment of low grade? What is the treatment of high grade squamous intraepithelial lesion? That's what they'll ask you. So either way, dysplasia classification they ask or Bethesda classification, you should know what is low grade and what is high grade, and treatment of low grade and treatment of high grade. That's what we have to know, whichever name they ask you for, right? Okay, let's move on and see what is the management of CN1. Now, CN1 is a very minimal lesion. Consider it, guys. CN1, less than 1/3 cells are abnormal. It is not a normal cervix, but CN1 less than 1/3 is abnormal. Look, I'm not saying CN1 to chalta hai. I'm not disregarding any low grade lesion also, because we must understand that a CIN1 that only becomes a CIN3 in 5 years, and a CIN3 becomes a cancer cervix in 10 years. I'm not going to ignore a CIN1, definitely not going to ignore, but it is a much milder lesion. So keep under observation. I'll do more frequent Pap smear. What is the frequency of Pap smear? Once in 3 years. I do yearly Pap smear in this one. So yes, CIN1 can be followed up with a core test in 12 months. You can try antivirals. That is 12 months means yearly Pap smear and HPV DNA. And you can check the HPV DNA today also, whether it is a high risk type of HPV DNA, the ones which I told you, the 16, 18, 31, 33, 45, 52, 58, that is high risk. And then, or it is a low risk, the other serotypes. So high risk, you'll be more concerned. Low risk, you can, you can see for it to by itself get better. So remember that 65 to 80% CN1 will regress spontaneously because it's a viral problem. You and me have viral fever so many times. Don't we get better? We all had corona also. Didn't we get better? Yes, 2% of us, 1 to 2% of us didn't make it after corona, but most of us survived. Similarly, don't think CIN1 हो गया तो इसको तो cancer cervix होके रहेगा. No, it's not like that. If it is CIN1, it doesn't mean automatically that it's going to become a CS cervix. If it is CIN1, follow her up, and more than 65 to 80% will become spontaneously all right. Okay, so CIN1, just like any other virus, may just go outside the body. So that's why we say CIN was a histopathological manifestation of HPV infection. It is not a cancer precursor. Yes, it may lead on to CIN3. That can become cancer. But CIN1 itself is not a cancer precursor. It becomes all right by itself, all right, in most of the cases. Now, what is the management of CIN3 or a high-grade squamous intraepithelial lesion? Now, this is the one which is coming in exams. So, what have we discussed? It is CIN3, that is more than 2/3 cells are abnormal. Now, what is the funda that we want to concentrate on here? Look, I have taken a smear. Concentrate, guys. Concentrate. Totally concentrate and nothing else now. I have taken a smear on the cervix. The cells are showing me, oh, more than 2/3 cells are bad. CN3. It will become a cancer in 10 years. It will become a cancer in 10 years. Correct. But who knows that it is already a cancer and you don't know? All you've done is a smear on the cervix, and smear is showing 2/3 cells abnormal. So if 2/3 cells are abnormal on the surface of the cervix, I'm trying to make some cells on the surface. Okay, 2/3 cells, I'll tell you here rather. See here. If 2/3 cells are abnormal on the surface of the cervix here, okay, transmission zone, these 2/3 cells which I've taken, they are abnormal. Suppose these cells which I've taken from the transmission zone, 2/3 cells are abnormal here. Now, these 2/3 cells are abnormal on the surface. Who knows that if 2/3 cells are abnormal, maybe one or two of them are already invading into the stroma. Who knows that one or two of them are already invading into the stroma? So if they are invading into the stroma, how will you know? Once again, concentrate. I have done a pap smear. What does the woman look like? She's absolutely normal. She has no symptoms. How does the cervix look like? Absolutely normal, sir. When I do a pap smear, CN3. अरे यार, इसको 10 साल में कैंसर हो जाएगा. Correct. CN3 can become cancer in 10 years. But make sure it is CN3 only. Because if it is CN3, majority of the cells, 2/3 are abnormal. A few could be invading already. So you must confirm that it is CN3. So how do you know if the cells are invading or not? Because if they are invading, then that is known as invasive CA cervix. Because if it is invading here, that means it will also start spreading to the lymph nodes. It will start going to the lymph nodes already. So if it is invading, then it is invasive cancer cervix. If it is just limited to the surface, then it is CIN3. So come again. What is the situation we are in? Healthy cervix, normal woman, Pap smear shows CIN3. So just CIN3 का treatment बताओ ना sir. अरे यार, it is a screening test which has shown me CIN3. I want to confirm that it is CIN3. Sir, how will you confirm it is CIN3? I'll take a biopsy of the cervix. When I take the biopsy of the cervix, I'll see if it is invading or if it is not invading. That is what is the meaning of the CIN3 management. Take a biopsy to show if it is invading or not invading. Because if it is invading, it is cancer cervix already. If it is not invading, it is CIN3. The biggest part of the chapter of CA cervix is what is the management of CIN3. So concentrate, guys. We are discussing CIN3. And if it is CIN3, the management is simpler. If it is invasive cancer, it is cancer cervix to be treated. Okay. So if it is CIN3, all right. Okay. If it is CIN3, do a biopsy to rule out invasive cancer cervix. You have to rule out invasive cancer cervix. So you have to do a biopsy here. Now, how do I do a biopsy? Where do I do a biopsy? Guys, be careful. When I'm looking at the cervix, cervix is normal. There's no growth hanging from the cervix of which I'm going to take a biopsy. Cervix is absolutely normal. When I do the pap smear, looking abnormal, CIN3. When I look at the cervix again, अरे ये तो एकदम normal है. And Dr. Vij is saying to take a biopsy. कहाँ से लूँ biopsy? Where will I take a biopsy? Because I have to see invasion, I have to take a biopsy. Where do I take a biopsy? The areas which will have more rapid cell division will have invasion. I'm not saying may always, may have invasion. So I have to find out which place to take a biopsy. I have to magnify my vision because the cervix looks absolutely normal to me. When the cervix looks absolutely normal to me, मैं biopsy कहाँ से लूँगा? To take a biopsy, I have to magnify my vision with the 15 to 40 times magnification and bright light I put onto the cervix, and with the magnification and illumination, I go and take a biopsy of the areas which are abnormal looking. Yes, when I magnify 40 times, arey yaar, there's a small ulcer here, there's a small leukoplakia here. If at all there are abnormal areas, they may be invasion. Look, I'm not saying there is an abnormal area, it will have invasion. No. I am saying that if there is a normal area, under that only invasion will happen. Invasion won't happen under normal looking areas. So what am I doing? CIN3, I'm taking a biopsy. Where do I take a biopsy? Abnormal areas on the cervix. How do I see abnormal areas if they're looking normal to me? I magnify my vision. So that magnification 15 to 40 times is what is known as the vaginoscopy. Vagina ka examination under bright illumination and magnification. Vaginoscopy. Now, vagina in Latin is also known as the colpos. So we call it colposcopic biopsy. I'm telling you, this is your major Viva question and major MCI question, PG entrance exam question. Colposcopic biopsy. Guys, concentrate. This is why I've been telling you, this is the 10th time asking you to concentrate in the class. So when I do CN3 management, I have to take a biopsy. And how do I take a biopsy? I do it with a colposcopy. Look, I'll just try to tell you a little bit more in detail and what we can understand here. So again, CIN3 Biopsy. How do I do the biopsy? By a colposcopy. What can you see on a colposcopy? In a colposcopy, if you see something like a leukoplakia, or you can see a small ulcer, those areas you'll take a biopsy. Colposcopy is 15 to 40 times magnification. 15 to 40 times, that is magnify under bright light, under a bright illumination. That is what is a colposcopy. Now, with the colposcopy, you could see an abnormal area and take a biopsy. You're lucky, because most of the times in colposcopy, we don't see anything. We have to put highlighters. Yes, now that is the next big part about the biopsy of the cervix. That I do a colposcopy, I do not see abnormal areas. So I have to throw some acid on the cervix, and acid will highlight the dividing areas. Yes, that's the next part. So I throw acid, and those areas which are rapidly dividing, they will become white in color, acetowhite, because they are having cell division. Cell division matlab protein formation. And when you throw acid on protein, protein precipitates, protein coagulates. So that will become white in color. So these are the areas which are rapidly dividing. Can you see this area which is white? This is because of acetic acid application, 3 to 5% acetic acid when you are applying. So this will become white in color. So this is the area which is having rapidly dividing cells. If at all there is invasion, it will be under this. Guys, please understand, concentrate once again. I am trying to take out a biopsy. I have to take a biopsy. I do a colposcopy. I saw abnormal areas. I take a biopsy. I could not see abnormal areas. I am putting highlighters to see abnormal areas. Now, where am I seeing some abnormal areas? Sir, यहाँ पे सेल डिवीजन हो रहा है. ये white हो गया है. एसिड की जगह एसिड लगाने से ये जगह white हो गई है. Okay, if it is white, that means there is rapid cell division here because proteins are formed. Now, under this, if there is invasion or not, that cannot be made out by looking at these white areas. I am finding out which area to take a biopsy. This whole 15 minutes we've been discussing how to take a biopsy. Guys, most important part. So, how to take a biopsy here? I will take a biopsy only if I see something abnormal. How do I see something abnormal? I do colposcopy. If that doesn't work, I use acetic acid. Acetic acid shows me acetowhite areas. I will take biopsy. So, biopsy is now taken from the acetowhite areas. Now, sometimes you don't see with that also. Then we have another method. We use iodine. We throw iodine on the cervix. Look, the iodine colors the normal areas brown, mahogany brown. Dividing areas will be colorless. Why? Because the resting cervical cells have glycogen in them. Glycogen becomes brown with the iodine. But the areas which are rapidly dividing are eating up the glycogen for the energy. Arey bhai, cell division needs energy, na? So that cell division is eating up the glycogen. So if you put iodine here, the cell division is already taking up the glycogen. So iodine won't stay in this area. So the brown areas are the normal cells, and this white area or unstained area is the one which is rapidly dividing. And where is the invasion? Against in under the resting cells or dividing cells? Under the dividing cells. So I take a biopsy in this white area. So where to take the biopsy? पकड़ के रखो टॉपिक, निकलने मत दो. टफ टॉपिक है, बता रहा हूं बार बार, पहले से बोल रहा हूं, टफ टॉपिक है, पकड़ के रखना है. So you're taking a biopsy from the area which is rapidly dividing. So white area in acetic acid, and now the area which is not stained brown because it is dividing and it is eaten up the glycogen. So all of that is written here. So you take the biopsy from the Lugol's negative areas. Next question, guys. You can also do a examination of the cervix with a colposcope using a green filter. This came in MCI exam, guys. What is the color of the filter used for a colposcopy? आपका question है MCI, guys. If you're watching this, so please, PG entrance students, you don't think that this is going out of course, okay? बहुत डिटेल में पढ़ा रहे हैं सर. अभी तो बेसिक डिटेल्स पढ़ा रहा हूँ. अभी तो इसमें बहुत कुछ और है. एटलीस्ट अंडरस्टैंड दिस मच. हाउ टू टेक अ बायोप्सी की बातें चल रही हैं. बायोप्सी का मैनेजमेंट क्या अभी आएगा थोड़ी देर में. ओके, सो यू टेक द बायोप्सी विद अ ग्रीन फिल्टर, एंड विद द ग्रीन फिल्टर you can see the abnormal vascular patterns. Abnormal vasculature is seen. So abnormal vessel pattern, like you'll see atypical patterns which could be, the branching vessels and branching at acute angles, branching at obtuse angles. So all those vascularity, if it is abnormal, those areas you take a biopsy. So vascularity of the cervix, the blood vessel, the division, the branching of the blood vessels is seen better with the colposcopy under green filter. So biopsy कैसे लेते हैं? That's what we're discussing here. All right, that's what we're discussing here, guys. So yes, summary of biopsy methods. So once again, if it is CIN3, then we do a biopsy to rule out invasion. Now this is the slide for you to remember. If you've not understood anything, remember this part at least. Then how do you take a biopsy? You do the biopsy by a colposcopy. Now colposcopy doesn't help, then I have these highlighters. What are the highlighters? The highlighters are like the acetic acid, and then we have the Lugol's iodine or the Schiller's iodine also we can use, and we have the green filter. So these are the highlighters we have to take this colposcopic biopsy. So when these highlighters are used, we can get a biopsy, and with the biopsy we can know if it is invasion or no invasion. All right. Now, this is the gist of what I taught in the last 5 slides. How to take a biopsy, colposcopy. If that doesn't show, I have these highlighters. But you are an intern who is working in a village. Suppose you're working as an intern in Jipma and we get posted to Ramnathpuram, 20 kilometers from Jipma. That's where we do our PSM postings. And in PSM postings, 6 weeks you're living in the village in a health center where you're delivering healthcare to people in the villages. Now you decide to do a Pap smear in Ramnathpuram village. In a village, you do a Pap smear, and when you're doing a Pap smear, the slides are sent to the Jipma college, and the college guys tell you a report that, sir, all the 15 patients you've done the Pap smear, but Virodambal, that one patient, her Pap smear is showing CIN3. You're in a village setup and the Pap smear shows you CIN3. Now you want to do a colposcopic biopsy. You can't do colposcopic biopsy because colposcopy is not there in Ramnathpuram. It is not there in many of the hospitals in the country. So now you have a problem. That's why we say that rather than taking her up for a colposcopic biopsy, what you can do is, in the village, you open the vagina with the speculum in the small health center which you have and look at the cervix with a vision, and the cervix looks fine to you. But now if you want to do more, you can apply acetic acid. Acetic acid, that bottle is 10 rupees worth, and 1 drop of acetic acid you have to apply. You apply acetic acid on the cervix, and with your eyes you can see Acetowhite areas. Those Acetowhite areas you can simply take a biopsy. So yes, if you do not have these highlighters, then this you don't, if you do not have a colposcope, then you can do a visual inspection under acetic acid, or you can do a visual inspection under Lugol's iodine. So yes, these two are the jugards. Yes, jugard is now an English word, guys. So yes, it's accepted in the dictionary now. Jugard, arrangement. Matlab, if you don't have the right kind of thing, then something else, a cheaper method can be used. So this visual inspection under acetic acid or the visual inspection under Lugol's iodine, this can help you. Just you apply the acetic acid, you don't have a colposcope, look into the vagina with your vision and you can see the Acetowhite areas if you have a good vision, and in those Acetowhite areas or the areas which are not stained by the iodine, those areas you can take a biopsy, and with the biopsy you can know if there's an invasion or not. This is how you take a biopsy. Now the interpretation of the biopsy, guys. Okay, where are we now? Okay, okay, so you're just listening. Good. So after biopsy of CIN3, okay, you have this condition where you've done a biopsy. Come, this is now the management part. Come, guys. So this is the transmission zone here and the transmission zone cells here, and CIN3 was there. You have to do a biopsy. How you do the biopsy, you've done that in detail. Once you do the biopsy, suppose you've taken a biopsy like this. In this biopsy, what do you see? Situation number 1, when you take a biopsy, you see that these cells on the surface, they are invading into the stroma of the cervix. So this, if it is invading, it is invasive cancer cervix. Yes, that is invasive cancer cervix, guys. So where, yes, I'm taking a small pause here. So I've done a colposcopic biopsy when it was a CN3. I've done a colposcopic biopsy, or I've done a visual inspection under acetic acid and taken a biopsy. I've done a biopsy. After the biopsy, it shows me invasion. The cells on the surface, they're actually invading. If they're invading inside in the biopsy, I could see it's invasive cancer cervix. So what is the treatment of invasive cancer cervix? You do a radical hysterectomy, isn't it? I mean, at least this much you should know. I mean, there are many subdivisions of the treatment, but at least this much you know. It's invasive cancer cervix. Radical hysterectomy you have to do. So this woman who was sitting in a home and she had no complaints, she was brought to the hospital because a health checkup is going on. I do a Pap smear, I see CN3, and when it was CN3, I do a colposcopic or any other biopsy. With the biopsy, I found out that there is invasion, and if there is invasion, it is CS cervix. So she did not have any symptoms, and I caught CS cervix before it could actually kill her. I have found CS cervix and I have treated her. That is what is the fun of doing a regular Pap smear. You can pick up these early lesions. Yes, what kind of CS cervix it is? Yes. Now itself we have to learn this. The CS cervix, what kind of CS cervix it is? Did you see the CS cervix coming out of the cervix and you could see a growth? No. Sir, this patient's cervix was absolutely normal. A normal looking cervix. This came to the OPD and in the examination I saw the cervix is normal, but the Pap smear showed me abnormal cells. So CN3 was there. So I did a biopsy. With the biopsy I found out there's an invasion. Is it a clinically obvious cancer? Or is it a microscopic cancer? You could make out only by microscopy. Stage 1 CS cervix coming. Stage 1 CS cervix limited to the cervix. 1A microscopic cancer. Yes, this is stage 1A of CS cervix. Depending on the depth of invasion, it is 1A1 or 1A2. CS cervix staging you have to know. CA breast, CS cervix, two cancers in women, you have to know the staging in and out. So stage 1 CS cervix limited to the cervix, and this is the microscopic CS cervix. Okay, now we'll come to the staging. Number 2, you've done a biopsy, the surface had abnormal cells, you know it was a CN3 in a Pap smear, you've done a biopsy and there is no invasion. There is no invasion. So it is still CIN3. This is what is known as a, please write this line, biopsy proven. This is a biopsy proven CIN3. Yes, guys, this is what you have to say. It's a biopsy proven CIN3. So now, this patient, Viradamba, like I said, this woman who was a village lady, and I did a Pap smear, it showed me CIN3. And when I did a Pap smear, when I did a biopsy of the CIN3, it showed me that there is no invasion. So I called the woman, Amma, you don't have any cancer. It is only a superficial lesion. Thank you, Dr. Saab. Can I go home? No. You have CIN3 still. It is not a cancer, I'm happy, but it can become a cancer in 10 years. I have to manage your CIN3. CIN3 का तो treatment करोगे, छोड़ोगे थोड़ा ना. So yes, it is biopsy proven CIN3. So what is the treatment of that? Yes, if there is a CIN3, so all you have to do is take a loop of wire which is high resistance wire, pass current through it, it becomes a red hot wire, and with that you can go and scrape off these cells. What are the cells which are having the abnormal cells? The transmission zone. You can scrape off that area, take off the transmission zone, because that's the one which is having the abnormal cells. There is no invasion into the stroma of the cervix. In the tissue of the cervix, there is no invasion. So this is what is known as a large loop excision of the transformation zone, LLETZ. But now we call it somewhat simpler name. We call it the loop, we call it the loop electrosurgical excision procedure. Yes, this you have to write, loop electrosurgical excision procedure. Yes, with this you scrape off the transmission zone. We do a leap. Okay, that is the best treatment. Yes, best treatment at any age. Look, You can also offer her, she's let's say a woman who is 40 years and beyond. What you can offer, you can cut this much of the cervix, you can do a conical resection of the cervix and throw the cervix off. So that is what is known as a conization. Or you can also offer a hysterectomy because she's completed a family. So I'm not writing also all of that because it's going to confuse you. Just remember, with age we have more options, but the best treatment which we want you to know, and any exam this will come, best treatment of CIN3, biopsy proven CIN3, it is always Leep, because you will save the cervix. And who knows, this woman wants to have a child, she's 35, she wants to have child. CIN3 can happen even to 28-year-old women who are sexually active for a long time. Will you take out the cervix in a woman who wants to have children? Even if she's 40 years, she says, no, I want to have my cervix, I'm planning to have a donor insemination done, or I'm going to have a donor eggs used, and I'm going to have a child later in my life. I'm very busy in my career, I don't want to have a conization or a hysterectomy. So don't think if she has children, then the only treatment is hysterectomy. No, that's a very bad notion about gynecology all of you have. Okay, yeah, we are partly responsible for you guys having that. Gynecologists to sirf hysterectomy karte hain. We are part of the gang because of which you have these impressions. But yes, the ideal treatment is, we do not do hysterectomy as the basic treatment. Okay, Leep is the basic treatment. Now if she says we can offer, she's 43, 44, sir, I've got 3 children, and with CIN3 I can have cancer. No, I'm going to treat it nicely. Sir, aap hysterectomy kar do, jhanjat hi khatam. Can offer, I'm saying we can offer, I'm not saying it is the best treatment. Best is always Leep. All right, many variations exist, understand the outright basics. All right, so we've come to this much. So CN3 always become cancer, can also regress. No, CN3 does not regress. Okay, good question. Future doctor, second time you're asking very, very good question. Last time also. No, it does not become, CN1 does not become a cancer always. It regresses, but CN3 will stay or progress. Spontaneous regression is not the common thing in CN3. You have to treat it. Okay. Chalo. After all of that, let's see the symptoms. Now, there's a cancer cervix, CIN3 over, get into cancer, and then wrap up the topic. So, symptoms of CA cervix, abnormal bleeding, and the most common bleeding is post-coital bleeding. फिर से मैं ब्रेक लेने वाला हूँ एक, यहाँ पे पॉज करेंगे. Post-coital bleeding is the most common presentation of CA cervix. What is the management of a woman who comes to you with post-coital bleeding? Don't look at this anymore. Come, talk to me. What is the management of a patient who has post-coital bleeding? What is the most common presentation of CA cervix? Post-coital bleeding. A woman comes to you and says, sir, I'm married for the last 5 years. I have 1 child. I'm 30 years of age. Recently, I've seen that whenever I have sex with my husband, I'm bleeding. Last 3 months, it's happening. Whenever I have sex, I bleed. Otherwise, I'm having regular periods. But जिस दिन sex होता है, उस दिन थोड़ा सा bleeding होता है, sir. Post-coital bleeding है. So what are you thinking in your mind? That whenever the penis is hitting the cervix, there is post-coital bleeding. Something's wrong in the cervix. Of course, post-coital bleeding can be because of vulvitis, vaginitis, cervicitis, all that is also there. But you'll always think of cancer first, because most common presentation of C cervix is post-coital bleeding. So yes, when there is post-coital bleeding, you'll examine. Listen to the question properly, guys, everybody. When a woman is having post-coital bleeding, examine the vulva. ठीक है. Examine the vagina. एकदम ठीक है. Examine the cervix. Healthy. Vulva, vagina, cervix. At the look of it, it looks absolutely normal. But what is there on your mind? Sir, post-coital bleeding hai, sir. It is the most common presentation of CS cervix. So what are you going to do? What are you going to do? Tell me. Come. Nobody answered so far. Koi baat nahi. I will lead you to the wrong answer first. All of you are going to say that if a patient is having post-coital bleeding, do a Pap smear. Arey yaar, Pap smear kar lena. I'm not saying it's a wrong answer, but Pap smear is how much sensitive? Yes, remember 47 to 62% only. It is not a 100% sensitive test. She has the most common presentation of CS cervix. What is the most common presentation of CS cervix? Post-coital bleeding. She's come to you. Sir, I have post-coital bleeding. In fact, the cervix is shouting from inside, hey, hello, sir, I may be having cancer here. And you're saying, no, I'll do a screening test. Arey, Pap smear is a screening test. How can you say Pap smear is the best method to follow up after a post-coital bleeding? It is going to miss in more than 40% of cases if there's a cancer. Pap smear is 47 to 62% sensitive. You miss, na? In roughly 40%, you'll miss a lesion. So Pap smear is a good screen test. Now she's symptomatic. अरे symptomatic में screening करोगे कि diagnosis करोगे? I know all your so many friends are screaming at you. Post-coital bleeding, do a Pap smear. You can do a Pap smear. I'm not saying it is not to be done, but it's not the best thing to be done. The best thing is this cervix could be having a early lesion of CS cervix because post-coital bleeding is the most common presentation. So this cervix, although it looks normal to me, I'm going to magnify my vision 40 times and look under bright illumination and look at the cervix and see if there is anything abnormal. Yes, colposcopic biopsy. एम्स का क्वेश्चन आ चुका है NICT का कि if colposcopy doesn't show, what do you do next after that? These questions have come to you and you keep saying Pap smear is the management. Guys, Pap smear is not the best management. Do a colposcopic biopsy and with that you rule out if there is a invasive lesion happening. All right, guys. So yes, always examination part we've always said that I said I told you vulva is normal, vagina is normal, cervix is normal. Now what do you do next? There is a lesion probably on the cervix because penis hits on the cervix and it bleeds. So you will do a colposcopic biopsy. Okay. So post-coital bleeding, I'm already telling you here. There are three things. Is that coming here? Wait, it's not coming here. Yeah, I'll write it here. So I told you CIN3. Look, this is the summary of what I am trying to inculcate all my students. This you have to inculcate now that if there is CIN3, you do a colpo biopsy, colposcopic biopsy. We discussed that. If it is carcinoma in situ, that means all the cells are abnormal. Again, you will do a colposcopic biopsy. And if it is post-coital bleeding, here also you will do a colposcopic biopsy. At least this generalization you should have. Yes, this much at least we should know. That CN3 you said colposcopic biopsy to rule out invasion. If it is post-coital bleeding and carcinoma in situ, then also you have to do a biopsy, and that is mostly colposcopic biopsy. Okay, after understanding this, symptoms of CS cervix once again. Now let us finish off the common things which keep coming in your exam. I took a segment of almost half an hour, 40 minutes where the intricate questions which come in your MCQ exams, I dealt with them. But yes, now getting back to the final year mode, and final year mode is what are the most common symptoms? Abnormal bleeding, post-coital bleeding is the most common. It can also be post-menopausal. Post-menopausal bleeding also can be there. One of the most common causes of post-menopausal bleeding in India is CS cervix. Then foul-smelling discharge, pyometra can be there, and that can cause dirty vaginal discharge. And then there will be, yeah, post-menopausal bleeding has come here again. Cancer, cachexia, loss of weight, loss of appetite, cancer pain, and then uremic symptoms, which are the most common cause of death. Most common cause of death is the uremia. All right. Uremia in CS cervix, because cancer cervix can involve the sides of the uterus and compress the ureters. That's why uremia. Why uremia happens? It is because of the cancer compressing the ureters and the kidneys not being able to give an output properly because of that. So this uremic symptoms, most common cause of death. So management of postcoital bleeding, like you said, do a local examination. See, rule out any lesion, take biopsy if any obvious growth is seen. If there's no growth seen, if the cervix appears normal, do a colposcopic biopsy. Do colposcopic biopsy. Just like you said, rule out any local lesion. See, you said, and I've already written it for you. Always do a perspective examination. Right. So this is the staging of CS cervix. Now CS cervix staging, I've tried to, guys, I don't think you can see it so well now. Highlight it. I can make it a little bigger for you guys to see. I want you guys to remember the staging, all right? Yeah, let's see if it is somewhat better. Yeah, somewhat better. All right, guys. So when I say CS cervix starts in the cervix. So I've given you some color codes. Guys, थोड़ा ना कंसिडर करेंगे. डिफिकल्ट पार्ट ओवर हो गया. अब जो रटने वाला पार्ट है, स्टेजिंग, this will come in the exam. CS cervix staging will come, and it is a 2.5 A4 size page staging, and I'm giving you half a page. If you go back and see, just half a page. So understand the staging with me. I've given you some color coding so that you understand it somewhat better. Okay? Okay. Stage 1 limited to the cervix. Now, what did I tell you? Limited to the cervix, but you could make out only with the biopsy, microscopic stage. So, stage 1 limited to the cervix, and one stage 1 is limited to the cervix. Here in this stage 1, just a minute, I'm trying to get the color which I can use: blue, green, purple, yellow. Okay, we'll take this. Okay, stage 1 limited to the cervix. Now, when it is limited to the cervix, if it is microscopic, invasion, it is stage 1A, microscopic. Now, in microscopic, if the invasion is less than, if it is invasion is, I'll try to show you with, now this I'll have to show you here. If the invasion is less than 3 millimeter or more than 3 millimeter. So, I'm saying the invasion is less than 3 millimeter. Maybe you can't see with your eye. If it is more than 3 but less than 5 millimeter, maybe still you can't see with your eye. So, less than 3 millimeter depth of invasion, 3 to 5 millimeter depth of invasion. I hope you're not reading transfer spread. That transfer spread more than less than equal to 7 millimeter, it is outdated. It's not there in the latest staging. Okay. So, depth of invasion only. So, I'm trying to show you with my hand here that if there is an invasion, see here. See here, if there is an invasion, if it is less than 3 millimeter, maybe you can't see with your eye. If it's 3 to 5 millimeter, maybe again you can't see with your eye. But if it is more than 5 millimeter, suppose it is 7, 8 millimeter depth of invasion, can't you see the black dot on my hand? Can you not see that black dot? Yes. Can you see that black dot on my hand? I made it like 7 millimeters. So if it is depth of 3 millimeter, you may miss. Depth of 5 millimeter, you may miss clinically. But if it is more than 5 millimeter deep, that means there's a growth which is more than 5 millimeter big. 6-7 millimeter की ग्रोथ है कोई. अरे तो अंधे थोड़े ना है, दिख जाएगा ना, मटर के दाने की जितना हो गया, पीनट से बड़ा हो गया, 6-7 millimeter का ग्रोथ है, तो हमें दिखने लग जाएगा. See, I'm trying to show you from the camera. I'm sure you can see this black dot which is 6-7 millimeter. So if it is more than 5 millimeter depth, then it is clinically obvious. That's what I'm trying to show you, that we are not blind. We can see that, isn't it? So yes, if it is 3 to 5 millimeter depth, you may not see, but if it is more than 5 millimeter, then you can see with your eyes. So that is stage 1B. It's a macroscopic cancer. See, now you can see B1 less than 2 centimeters, B2 2 to 4 centimeters, B3 more than 4 centimeters. So black, limited to the cervix, microscopic, macroscopic, limited to the cervix. From the cervix, where will it go? From the cervix, it will go to the organ next to the cervix, which is the vagina. Look here, guys. From the cervix, green growth. It is involving the upper vagina, 2A. Involving the lower vagina, it is not 2B, it is 3A. Concentrate, guys. If the growth on the cervix is involving the vagina, it is upper vagina 2A and lower 1/3 vagina is 3A. Don't say 2A and 2B. No, 2A is upper vagina, 3A is lower 1/3 vagina. Now, from the cervix goes to the vagina, upper and lower. From the cervix, it goes to the vagina and involves the parametrium. See, this is endometrium. This is muscle, myometrium. After the muscle, it is gone to the parametrium. So, parametrial growth, parametrium is involved. Then that becomes 2B. Parametrium 2B, blue, parametrial growth, but short of the pelvic wall, this pelvic side wall. So, if you look at this pelvis here, see, there's a growth in the cervix. How do I show that to you? Yes, here. See here? See, there's a growth. There's the uterus and there's a growth. Now, the growth is gone outside the cervix. See, it is going from the cervix outside here. From the vagina, it's gone outside, parametrium. See here, growth is going to the parametrium. Now, it goes to the parametrium and does not involve the wall. That means it is 2B. But if it goes till the side wall of the pelvis, the growth is gone and is involving the pelvic side wall. It is involving the bone of the pelvis. Now, that is going to be a very painful cancer. All right. So, that is what is 3B. So, yes, 2B is parametrium involved, not to the pelvic side wall. And if the growth goes from the cervix to the vagina until the pelvic side wall, here it is involving till the pelvic side wall. That means from the cervix all the way till the pelvic side wall. There is no cancer-free area. That is what is known as a stage 3B. Stage 3B, parametrium till the pelvic side wall. It is bony pain. Cancer of the bone has started now. The bone is involved in cancer. Now, no woman, she'll be having dirty, foul-smelling discharge, post-coital bleeding, cancer cachexia. She's sitting at home. One fine day, the growth goes and starts involving the bone. That pain will bring her to the OPD. That's why, guys, most common stage to the OPD in India, obviously, is stage 3B. Most of the times when they have CS cervix, you do an examination in the OPD, you will have stage 3B. Yes, clinical staging of CS cervix. Now you know the reason why. All cancers in gynae are staged with a surgery. Yes, surgical staging is done. Only CS cervix. Yes, this is a clinical staging. So that's why I did not tell you this line before the staging started, because now you'll understand. With the PV, I see a growth and I feel the growth into the vagina, upper vagina, lower vagina. Then I put my finger behind the vagina. I put my finger outside vagina, go behind the vagina into the rectum, one finger. Then I feel the parametrium with the PR. So parametrium involvement till the pelvic side wall is stage 3B, most common stage of CS cervix. So with the pain she will come. And what else? The ureter, guys, the ureter will get compressed in the growth and there will be a hydronephrosis. So this is that favorite question coming in all the exams, entrance exams. Where do you see hydronephrosis of the kidney? Which stage? Stage 3B. The most common stage in OPD, 3B. Which stage has hydronephrosis? 3B. And that's why they ask you the treatment of 3B all the time. Yes. Treatment, we'll just summarize. Not to worry, we'll get into the staging now. Now, what has come latest? Stage 3C, I've given it in red. It is not shown here. The involvement of the pelvic lymph nodes and the parotic lymph nodes, C1 and C2. After 2018, this staging has come. Okay, this was modified by the work done by us Indians. Okay, so much of work, and doctors from AIMS and then Dr. Jonathan Berek, they all got together to write a major landmark paper, and that paper, the FIGO accepted the findings and the work done in the developing countries. That's the reason why this has been included in the staging. The pelvic and the parotic lymph node involvement, stage 3C. Endometrial cancer also has this stage. Now, in CS cervix, you have this stage. So, clinical staging plus one imaging technique, maybe an ultrasound or an MRI or a CT or maybe even a PET CT is done to see pelvic and parotic lymph nodes. Any one of this is done. So, clinical staging plus an imaging is what is done for the staging of CS cervix. Of course, for bladder and bowel, you have to see cystoscopy and proctoscopy. So, yes, bladder and bowel involvement, 4A and 4B is distant metastasis. But remember, there is no inguinal lymph node involvement. Yes, inguinal lymph nodes are not involved. So, where will I write that? Remember, inguinal lymph nodes are not involved in CS cervix. So, what are the lymph nodes? The sentinel lymph nodes of the cervix. You have the external iliac. You have the external iliac group of lymph nodes and the obturator group of lymph nodes. These are the two lymph nodes. Look, pelvic lymph nodes. The cervix is here. If you see this and see the cervix, cervix is, yes, inside the pelvis. You can make out inside the cervix. So in CA cervix, don't say inguinal and femoral. That is in CA vulva. Don't say inguinal and femoral. Those lymph nodes are not involved in CA cervix. So I've already told you inguinal is not involved. But yes, next to the cervix, see the external iliac, then the obturator. So external iliac and obturator group of lymph nodes are the ones which are involved. So these are the sentinel for the cervix. All right. So sentinel lymph nodes for the cervix are the external iliac and obturator, and the treatment of CS cervix. So treatment of CS cervix, grossly I'm just telling you, from stage 1 to 2A1 is a radical hysterectomy. And after 2A2 and beyond, the surgical treatment is not enough. In fact, surgery will be much bloody and the lesion is very big also. That's why surgical treatment is not enough. See, we don't do surgical treatment, you may not be able to get complete clearance. So beyond stage 2A2, we say a chemotherapy, radiation plus chemotherapy. So that's why the word used is chemo radiation. At least this much you should know. Chemo radiation. What are the methods of giving chemo? Which is cisplatin mostly. Radiation at how much of radiation you give at the various points. All of that is some other expansive discussion, and generally not bothered with the final year MBBS students. Definitely chemotherapy based with cisplatin, radiotherapy based by, you can give brachytherapy, teletherapy, brachytherapy with ovoids and tandems. All of that, many things are there in radiation. That's a separate long chapter. But remember, chemo radiation, you must say. That is stage 2A2 and beyond, chemo radiation. I'm not saying surgery plus chemo radiation. No, I didn't say that at all. I'm saying chemotherapy and radiotherapy together, but no surgery. Surgery cannot be done. So till stage 2A1, radical hysterectomy, surgical removal, and after 2A2, we say radiation and chemotherapy together, chemo radiation. All right. Right, guys. So that's what I wanted to convey. The outright core basics we should understand. Special interest I had to convey the management of the Pap smear, and when the Pap smear is showing CIN3, you must rule out if there is a cancer, because CIN3 management is simpler, but cancer is like what I told you. So with that, we must understand that colposcopic biopsy and other methods of highlighting that biopsy, that is the core topic which I wanted to teach you today, in addition to the vaccination. So what are your doubts, guys? Yes, shoot, what are the doubts? It's a rather long chapter. Yes, in the I think it's almost 1.5 hours, so maybe more, that we've been doing this. So what are your doubts on this? Sudha Prasamanta, colposcopy biopsy, please tell once. Colposcopy means you have to magnify your vision. You're looking at the cervix, you magnify your vision by 15 to 40 times, and under bright illumination you can see the abnormal areas, Sudha, and you look at the abnormal areas. Those areas, the abnormal areas will have the invasion. So what are the abnormal areas? That's what we want to see, and then only we can take a biopsy. So what is the method of looking at abnormal areas? By doing a colposcopic examination. Okay, if that doesn't show, we use acetic acid and use Lugol's iodine. Yes, repeated. Why no surgery done? Because you cannot do the surgery. It's a very big lesion. See here. See here. Stage 2A2. See, 2A2. Stage 2A2 beyond. So 2A is upper vagina, and 2A1 is less than 4 centimeters, 2A2 is more than 4 centimeters, isn't it? So when you have a lesion more than 4 centimeters, this lesion is more than 4 centimeters, it is too extensive, you can cut the cervix, but the inflammation around this is a much bigger cancer, and it can bleed much more during the surgery. So you will not get complete clearance in big lesions. Yes. All right. I guess we'll call it a evening now, and if you have more doubts, I always encourage you, but I keep looking at the chat. You ask me doubts in the live chat, but I never see any doubts in the chat after the session is over, because that is the only way which right now I feel that once you have a discussion, then once this session is over, then below the chat, below the video, there are this comments. In that you can put up your questions, and we can always answer you there also. Right, guys? So thank you so much for your attention. I hope all of you got the basics which I want to tell you. And for more doubts, you're always welcome to the PW forum. Thank you, guys. Good night.